Hey guys, I'm going to discuss in this video about semen analysis, one of the main tests to evaluate the male infertility, those couples who have. So let me start. So the semen analysis used to be an important test for male infertility. So today I'm going to discuss as per the WHO, World Health Organization, and laboratory parameters. So WHO has published lower reference limits for the semen analysis. So means the minimum lower limits. It was actually one of the study conducted on 1900 men whose partners had a time to pregnancy of less than 12 months. So a minimum volume of ejaculate semen should be above 1.5 ml, which is 95% of the standard percentile. Number second point is a sperm concentration per ejaculate, which is 15 million spermatozoa should be in each ml. Third component is total sperm number should be minimum above 39 million spermatozoa per ejaculate. And number fourth point is morphology 4% normal forms, which is there is a standard method. So a standard strict criteria is above 4% sperm should be in normal form. So vitality is number fifth point is 58% should be live and healthy. Number sixth point is progressive motility 32%, means per ejaculate the 32% of the sperms should be progressively motile. And total progressive and non-progressive motility should be above 40%. So these are the seven criteria, seven important numbers. Now I'm going to interpret a different ranges and issues with this. Let me just go ahead. This is very important. Men with the normal semen analysis. Male partners in an infertile couple may have an idiopathic male infertility. Now some of the people or the male particularly who have everything normal but they still have issues. So the possibility could be infertility of a female partner, couple's infertility factor, insufficient frequency. Now again, it's a variable, but every 2 to 3 days, unprotected vaginal intercourse should occur at least. Now again, as I say, 1 to 2 times weekly, so should be every 2 to 3rd day. This is the optimum, 6 months to 12 months. After complete evaluation of a female partner and the treatment of reversible causes of female infertility, means when the male have a normal sperm parameters, then likely either the frequency should be every 2 to 3rd day, or you can evaluate the female partner. Now I'm going to discuss about men with abnormal semen analysis. So for example, if a person who have a normal sperm concentration but abnormal morphology and motility, I think this is the most common thing in the communities where the males and infertile couple usually seek. An infertile couple with the male partner who has a normal sperm concentration but abnormal sperm morphology and motility, those candidates should need to a specialist referral. They might go for intracytoplasmic sperm injection, simply I would say just for the IVF. If a person who has a sperm concentration less than 5 million per ml, now most of the time, not most of the time, but some people who has less than 5 million, and among those there is a one genetic condition we call it as a Klinefelter syndrome. It's common in those men, those who have a sperm concentration less than 5 million per ml. Then we need to have a total serum testosterone to check in between 8 and 10 a.m. So normal, testosterone should be done in the morning. Then you have to evaluate with the FSH, LH measurements as well in those candidates who has a less than 5 million. Now there is another third category, severe oligospermia or azoospermia. Men with azoospermia or severe oligospermia also need endocrine testing. Further evaluation also depends upon the results. In addition to undergoing endocrine testing, men with oligospermia, azoospermia require genetic testing. As I say, Klinefelter, there are a few genetic conditions, chromosomal analysis. Some men may require transrectal ultrasound evaluation of obstructive azoospermia. So some people can need to see a urologist if there is an obstruction in the, there is a different structures in the male genitalias, because obviously sperm formulation occurs in the testicles and then they go through a proper channel in the ejaculatory duct. So there are a number of the tests with the specialist endocrine doctor do, like testosterone, LH, FSH. Now what happens if there is a low testosterone and a high FSH, LH? Low testosterone, high FSH and LH. This condition is called as primary hypergonadotrophic hypogonadism. Obviously these are very tricky terms. Even a medical student, doctor usually confused with these. So I think this is very expert things a common public may not understand, but I just to go through. So if there is a low testosterone and a high FSH, LH, this is called as primary hypergonadotrophic hypogonadism, affecting both spermatogenesis and the Leydig cells in the testes. These men should have a karyotype performed. Some experts do not recommend a karyotype if there is another clearly identified cause of primary hypogonadism. However, Klinefelter syndrome is common enough in infertile men with primary hypogonadism that karyotyping is reasonable even in the men with another cause. So I think when there is a low testosterone, if you have a suspicious some body habitus, if endocrine doctors used to evaluate and then they do these tests, and after then they can go for a karyotyping. Now normal testosterone and LH and high FSH. Now here is a point, normal testosterone and LH but only high FSH. So this condition is called primary hypergonadotrophic hypogonadism. Seminiferous tubule damage without Leydig cell dysfunction, only seminiferous tubule. These men have isolated defects in spermatogenesis and intact sex hormone steroidogenesis with normal circulating testosterone. So there is a seminiferous tubule damage. Low testosterone but FSH and LH not elevated, means normal. This is called as secondary hypogonadotrophic hypogonadism. Low testosterone, normal or low FSH, LH. Secondary hypogonadotrophic hypogonadism. Serum prolactin should be measured in men with the low serum testosterone concentration and normal to low serum LH. Now some other conditions can also involve, like iron overload syndromes should be excluded with iron studies. Men with low serum testosterone and low gonadotropin concentrations should be evaluated for a cellular mass, means some pituitary brain imaging should be required. There is a condition called as a high testosterone and LH but normal FSH. This is called as partial androgen resistance. Then normal testosterone, LH and FSH. So some of the other tests can be required: scrotal ultrasound, as I mentioned, urology review, endocrine review, brain imaging, hormonal test. These all are the important tests. Now, some men who have a low volume, low semen volume with the normal sperm concentration is most likely due to incomplete collection of the ejaculate or partial retrograde ejaculation. Now, retrograde ejaculation, it means some, like anyone who have the, sometimes they go with the urine, so it is a pussy. A lot of people have this condition, they have a UTI, they have some sphincter problem. So those patients should ask to return for a carefully collected repeat semen sample. After emptying the bladder, post-ejaculation urine can be collected. Here comes urine analysis, UTI, some other problems. So what happened retrograde means some of the sperm and semen can go back to the bladder. Low semen volume and low sperm concentration may also be seen in some men with testosterone deficiency. So overall, testosterone is one of the important thing. Low volume with azoospermia. Azoospermia means no sperm, and oligospermia means severely subnormal sperm concentration suggest genital tract obstruction, congenital absence of vas difference. Now these are some of the structural anatomical names: vas difference, seminal vesicles, ejaculatory duct obstruction. Congenital absence of vas difference is suspected by physical examination, confirmed by scrotal transrectal ultrasound. Low concentration, lower reference limit for sperm concentration is 15 million. However, some men within sperm counts considered to be low can be fertile. Even if you have a 5 million, you can be fertile. If you have a 30 million, you may not be fertile. So that's why some people can go for IVF. So in addition, for the purpose of IVF, 10 million, even less, can be satisfactory, as I mentioned just now. Lack of sperm in the ejaculate does not indicate the absence of sperm production. These patients should be evaluated for retrograde ejaculation, congenital absence, as I mentioned. Now it comes to the abnormal morphology. The criteria of sperm morphology are based on the length, width ratio, area occupied by acrosome. Now this is again the sperm morphology, neck, tail defects. Sperm morphology assessment has a modest clinical value. So morphology is important. Means how healthy is the sperm in overall. Some people have like any inflammatory condition in the body, any other associated stressful condition, free oxygen radicals in the body, they may damage the sperm in morphology. Poor motility, one of the factor. In general, the motility is not an important factor in independently predicting the possibility of natural pregnancy unless a very high percentage of sperm in ejaculate are immotile. Men with a very high percentage of immotile sperm might still be treatable with ICSI, intracytoplasmic sperm injection, means IVF. Now, prediction of fertility. Standard semen analysis provide descriptive data that do not always distinguish fertile from infertile. So it's just basically it is a recommended test. However, the numbers may not be sufficient to describe about how much someone have a pregnancy. So a semen volume can be repeated once. If it is abnormal, it doesn't mean that there's enough, but you have to have another repeat semen test. Ideally should be in the office, like a doctor office or collection unit. Should be go with the masturbation, but someone can go in the home or any available area. But the sperm container should be transported to the lab within 1 hour on the body temperature. So I hope you can have some understanding, just a basic understanding about the semen analysis. Thank you.